Hello, everyone, and welcome to our module on vertebrobasilar stroke syndromes. So in the video on cerebral strokes, I talk about how the blood supply to the central nervous system is broadly divided into two systems. The anterior system is a system of blood vessels that's supplied by the internal carotid arteries, and the major vessels in the anterior system are the anterior cerebral artery and the middle cerebral artery, which supply major lobes of the brain. And so if you look at this drawing over here, which shows the circle of Willis, everything sort of above this line is the anterior circulation. Most of the blood flow comes in here through the internal carotid arteries. In contrast, the posterior circulation is everything down here. It gets its blood supply from the two vertebral arteries, this is one here, which come together and form the basilar artery. So this posterior system is sometimes called the vertebrobasilar system. And it gives off one blood vessel that supplies the lobes of the brain, the posterior cerebral artery. This supplies the occipital lobe and the visual cortex. But then it gives off all these vessels down here, which are basically vessels that supply the brainstem. And so, as we'll see in this video, most of the stroke syndromes involving the vertebrobasilar system are stroke syndromes that involve the brainstem and the cerebellum. So that's a nice segue into the topic of this video, which is vertebrobasilar stroke syndromes. And as I just said, these often affect brainstem structures like cranial nerves and also the cerebellum. Importantly, in a vertebrobasilar stroke, you usually won't see any anterior cortical signs, which I talk about in the video on cerebral strokes. So these are things like Broca's or Wernicke's aphasia, or hemi-neglect from damage to the parietal lobe, or gaze preference, which indicates damage to the frontal eye field. All of these things are signs that there's damage to the anterior circulation structures like the frontal and parietal lobe. The one cortical sign you can sometimes see from vertebrobasilar stroke syndromes is homonymous hemianopsia. This indicates damage to the occipital lobe, which is supplied by the posterior circulation and the posterior cerebral artery. And so if you have ischemia of the PCA, this can sometimes lead to homonymous hemianopsia. In the video on the brainstem, I talk about the brainstem blood supply, and I talk about the major vessels that supply blood to the brainstem being the posterior cerebral artery, the AICA and the basilar artery, and also the PICA and the anterior spinal artery. And so in this video, we're going to talk about strokes involving all of these vessels which come off the vertebrobasilar system. But the point I want to make to you here is that this video is closely tied to the brainstem video. So you may want to watch that one first, because all the stroke syndromes we're going to talk about in this video involve structures in the midbrain, pons, and medulla, and all the cranial nerves shown here on this slide. So for the rest of this video, I'm going to go through 5 vertebrobasilar stroke syndromes involving these 5 vessels shown here. And if you look at this drawing on the slide here, we can find these 5 vessels. So this is the superior cerebellar artery shown right here. Basilar artery is a midline structure right here. This is the anterior inferior cerebellar artery. This is the posterior inferior cerebellar artery. And then right here, we have the anterior spinal artery. Okay, so we'll start by talking about strokes involving the superior cerebellar artery. This is the rarest form of cerebellar stroke. It can involve portions of the brainstem like the pons and the midbrain, but mostly it involves the cerebellum. And so the dominant clinical features of this stroke syndrome are ipsilateral cerebellar ataxias, gait and balance problems. And if you don't understand what I mean by an ipsilateral cerebellar ataxia and why that occurs with a stroke of the cerebellum, watch the video on the cerebellum where I talk about this in detail. Other cerebellar symptoms you can get are nausea and vomiting. This goes with many forms of cerebellar ischemia. You can also sometimes see diplopia, and that's because the trochlear nerve is found in the brainstem in the regions affected by this blood vessel. Now, as we'll see in a minute, when you see clinical symptoms of cerebellar ischemia, it will make you think of strokes involving the anterior inferior cerebellar artery or the posterior inferior cerebellar artery. But strokes involving these vessels, which we're going to talk about shortly, involve hearing loss and hoarseness from damage to cranial nerves found in the medulla. You don't see these things in a superior cerebellar artery stroke. The patient is mostly going to present with cerebellar symptoms, maybe with some diplopia. Okay, next let's talk about strokes involving the basilar artery. So this is the basilar artery right here. It is a midline vessel. And so when there's ischemia involving the basilar artery, that can lead to bilateral symptoms, not symptoms just on one half of the body like you often see with brainstem strokes. So the pons, the medulla, and the lower midbrain can all develop ischemia from a basilar artery stroke, but the symptoms will be bilateral. So because the symptoms are bilateral, patients with basilar artery strokes can develop what's known as the locked-in syndrome. This occurs due to loss of the corticospinal and corticobulbar tracts on both sides of the body so that the patient develops bilateral paralysis, quadriplegia, and also often inability to speak and use the muscles of the face. Usually the patient will be able to blink. That's because the upper brainstem is intact, but otherwise they will be unable to move or communicate. And if you've never seen the famous movie Johnny Got His Gun about a soldier injured in World War I who develops the locked-in syndrome, go see it. It's a very grim depiction of what it's like to be alive but unable to move or communicate. And you should be aware that there's another condition in medicine that can somewhat resemble a locked-in syndrome, and that's called a vegetative state, but that's something different. So in a vegetative state, the person's motor function is actually intact, but they have widespread cortical dysfunction. And as a result, they are unaware of their surroundings and can even lack consciousness. That's sort of the opposite of a locked-in syndrome. In a locked-in syndrome, the patient is fully conscious and aware of their surroundings. They just have no motor function, so they can't move their limbs or communicate. There's a subtype of basilar artery stroke that can lead to what's known as the top of the basilar syndrome, so let's talk about that now. So this occurs when there's a stroke involving the top of the basilar artery, the upper basilar artery, just before the takeoff of the posterior cerebral artery. When this happens, you're going to continue to get perfusion to these lower basilar artery branches that supply the brainstem. The main thing that's going to happen is you're going to have ischemia of the midbrain, which is what the upper portion of the basilar artery supplies, and also the thalamus and the occipital lobes. And because of occipital lobe ischemia from decreased blood flow into the posterior cerebral artery, patients can develop what's known as cortical blindness. This is the term we use when patients' eyes and optic nerve are intact, but they are unable to see because of damage to the occipital cortex where the visual cortex is found. These patients can also have visual hallucinations. This is all related to occipital lobe damage. You can also sometimes see a vertical gaze palsy in the top of the basilar syndrome. This is because of the pretectal area of the midbrain, which is what coordinates vertical gaze, meaning having both eyes look up or down together, different from horizontal gaze where we're looking left or right. And then finally, there's a portion of the reticular activating system found in the midbrain, and if this becomes ischemic, that can lead to altered consciousness. Motor function, meaning movement of the face muscles or the arms or the limbs, can be intact or diminished depending on whether there's damage to the corticospinal or corticobulbar tracts. But this is somewhat distinguished from a basal artery stroke like we talked about in the last slide, where patients get locked in. In the top of the basilar syndrome, the problems are usually more related to visual problems and occipital lobe damage. Let me pause and make a quick aside about something that is not a vertebrobasilar stroke syndrome, but it can resemble one, and that is central pontine myelinolysis, also known as osmotic demyelination syndrome. This is a syndrome caused by demyelination of axons, meaning nerve fibers that run in the center of the pons. It occurs when there's a lesion at the base of the pons towards the middle of the pons. Patients with this condition lose function of the corticospinal and corticobulbar tracts, and this can lead to something similar to a locked-in syndrome with quadriplegia and sometimes inability to communicate. This syndrome is caused by overly rapid correction of hyponatremia. So when patients present with hyponatremia and you correct that by fluid restriction or giving intravenous saline solutions, you have to be careful not to correct too rapidly, because if you correct too rapidly, demyelination of axons in the pons will occur. And so I talk about this a lot more in the renal section in videos on sodium disorders, but there's a mnemonic that students use to remember this condition, and that mnemonic says, "From low to high, your pons will die." And this is to remind you that if you too quickly correct low sodium to high sodium, you can damage the pons. Along with this mnemonic is the line, "From high to low, your brains will blow." And this is a reminder that if you over rapidly correct hypernatremia, you can lead to cerebral edema. And once again, I talk about all this in a lot more detail in the sodium videos in the renal section. Okay, next let's talk about strokes involving the AICA, which is the anterior inferior cerebellar artery. Strokes involving this vessel lead to a lateral pontine syndrome, and it gets its name because you have damage to structures found in the lateral portion of the pons. And I talk about all these structures in detail in the videos on the brainstem. So what do you find in the lateral pons? Well, first of all, you find nuclei for the vestibular nerve. So damage to this structure leads to vestibular symptoms like nystagmus, vertigo, and nausea and vomiting. Also in the lateral pons, you find the spinothalamic tract fibers. So damage here leads to sensory loss related to pain and temperature on the contralateral half of the body. You also in the lateral pons find the spinal nucleus of cranial nerve 5, the trigeminal nerve. So damage to this structure leads to sensory loss in the face involving pain and temperature on the ipsilateral side, meaning the same side as the stroke. And then finally, in the lateral pons, you can find sympathetic nervous system fibers, and so damage to these tracts leads to Horner syndrome. And we'll talk about what a Horner syndrome is in just a minute. It's a clinical syndrome of features involving the face. The facial nucleus is also found in the lateral pons, so damage to this structure leads to ipsilateral facial droop and also loss of the corneal reflex. You also find cochlear nuclei in the lateral pons, so damage there can lead to deafness. And then finally, you find fibers of cranial nerve 7 in the lateral pons, so damage here can lead to loss of taste in the anterior portion of the tongue. Okay, next we'll talk about a pica stroke, which is a stroke involving the posterior inferior cerebellar artery. Strokes involving this vessel also lead to damage in the lateral brainstem, but the pica is found near the medulla, not the pons. So with AICA strokes, you get damage to the lateral pons. With PICA strokes, you get lateral medullary strokes. And this leads to a lateral medullary syndrome, also known as Wallenberg syndrome. So what do you find in the lateral medulla? Well, first of all, you can find vestibular nuclei here as well, just like we talked about with AICA strokes. So this can lead to vestibular symptoms like nystagmus, vertigo, and nausea and vomiting. Sympathetic tract fibers are found here, so that can lead to Horner syndrome when they're damaged. You find spinothalamic tract fibers in this region of the medulla, so damage here can lead to contralateral sensory loss in half the body related to pain and temperature. And once again, you find that spinal nucleus of cranial nerve 5, and damage here leads to ipsilateral face loss of sensation for pain and temperature. And then finally, in the lateral medulla, in a lateral medullary syndrome, you can get damage to the nucleus ambiguus, which is a combined nucleus that has fibers related to cranial nerves 9 and 10. So damage here can lead to hoarseness, dysphagia, and loss of the gag reflex. And if it's confusing to you why all these different structures are damaged in a lateral medullary syndrome, just watch the video on the brainstem and the rule of fours, where I go through how to recognize where all these different nuclei and tracts are located in the brainstem. Let's briefly review Horner syndrome, since this comes up in lateral pontine stroke syndromes and also lateral medullary stroke syndromes. So Horner syndrome occurs anytime there's compression or disruption of sympathetic ganglia, which send nerve fibers to the face and eyes. So the way the sympathetic nervous system works is it begins in the hypothalamus, but from there, nerves travel down to the region around T1 near the spinal cord, and then other nerve fibers travel back up to the face and eyes. So a lesion anywhere along this entire pathway, and there's a lot of real estate there for lesions to occur, lesions anywhere along this pathway, that can lead to Horner syndrome, which is loss of sympathetic innervation to the face and eyes. So Horner syndrome is a triad of clinical features. The first is meiosis, second is ptosis, and the last is anhidrosis. So meiosis refers to small constricted pupils. Usually it'll be on one half of the body when only half of the body is affected by Horner syndrome. So this means the patient will present with unequal pupils, and the affected side of the body, the side where there's a lesion causing Horner syndrome, that will be the side with the smaller miotic pupil. Also on the affected side, you can get drooping eyelids, which is called ptosis, and also you can get a lack of sweat, which is anhidrosis. And now most patients don't notice that they're unable to sweat, but what they will notice is half their face will become bright red. And that's because when you're unable to sweat, you're unable to dissipate heat, and so vasodilation will occur, and that will lead to redness of the skin. Okay, the last vessel we're going to talk about in this video is the anterior spinal artery. So if you look at our diagram, which we saw in the beginning of this video, this is the anterior spinal artery here. It receives blood flow from both vertebral arteries. It's a midline structure, so when you have ischemia of this vessel, midline structures get affected. And depending upon which portion of the anterior spinal artery has ischemia, you can see clinical features related to the medulla in the brainstem or in the spinal cord. So if you have an anterior spinal artery stroke at the level of the spinal cord, this will lead to a spinal cord stroke. Spinal cord strokes are very rare, but they do happen. And I talk about these in more detail in the videos on the spinal cord. But basically what will happen is, if you look at a cross-section of the spinal cord right here, when you have ischemia involving the anterior spinal artery, you're going to get ischemia in this entire region of the spinal cord, shown in blue right here. This leads to what's known as an anterior spinal artery syndrome. Basically, the anterior spinal artery supplies the anterior two-thirds of the spinal cord, this entire structure shown in blue here. When you have an anterior spinal cord syndrome, you lose all function of the spinal cord except the posterior columns. These are the posterior columns back here. They carry sensory information on vibration and proprioception, so that will be intact. But otherwise, below the lesion, you will have paralysis and loss of motor function. You will also have sensory loss as well. You can also have a stroke involving the anterior spinal artery that occurs at the level of the medulla. In this case, the critical features are going to be those of a medial medullary syndrome, meaning structures in the medial medulla are damaged. So what are the major structures you find in the medial region of the medulla in the brainstem? Well, first of all, you find the corticospinal tract fibers. So damage to these fibers leads to contralateral hemiparesis. You also find fibers of the medial lemniscus in the middle portion of the medulla. And so damage to these fibers leads to contralateral loss of proprioception and vibration sensation. And then lastly, cranial nerve 12 is found in the middle portion of the medulla. So damage to this cranial nerve leads to flaccid paralysis of the tongue. And classically, the tongue will deviate toward the side of the lesion if you have ischemia involving half of the medulla. So the last three blood vessels we described, the AICA, the pica, and the ASA, they can have stroke syndromes that are hard to remember and distinguish from one another. So on this slide, I've summarized the key points about what regions of the central nervous system are ischemic when you have a stroke involving these vessels and some of the key findings that we talked about in the last slide. And after you're done with this video, go and do the associated questions. We've got practice questions where all the stroke syndromes related to these vessels are described so that you can learn how to recognize them in a question stem. Okay, the final topic for this video is subclavian steal, which is not a vertebrobasilar stroke syndrome, but I'm talking about it here because it's related to the vertebral arteries, which are part of the vertebrobasilar system, and I just thought this was the best place to put this topic. So subclavian steal refers to flow reversal, in other words, backwards flow in the vertebral artery, diverting blood flow away from the brain, and it's caused by stenosis of the subclavian artery. Now, you may be wondering, why would stenosis of the subclavian artery cause the flow to reverse and go backwards in a vertebral vessel? And if you want to understand this, let's look at this diagram shown in the slide here. So this is the right side over here. This is the left side over here. We've got the right subclavian artery shown right here, and we've got the left subclavian artery shown right here. And as you can see in this cartoon, there's a stenosis or occlusion in the left subclavian artery. So what that's going to do is generate a region of very low pressure right here in the subclavian artery on the left side beyond the stenosis. Basically, you're underfilling this vessel out here, so it's going to have very low blood pressure. And if the pressure is low enough, what will happen is instead of blood flowing up the vertebral artery on the left side like it should, you will get blood flow going up the right vertebral artery to the point where the vertebral arteries meet and form the basilar artery, and then you're going to get blood flow coming back down through the left-sided vertebral artery. This is called subclavian steal. Basically, the subclavian artery right here is stealing blood from the vertebrobasilar system by drawing it backwards down one of the vertebral arteries. That's subclavian steal physiology. So what are the clinical features that this is going to lead to? Well, first of all, there will be a blood pressure discrepancy. You're going to have low blood pressure over here in the left arm because of this stenosis, and you're going to have relatively higher pressure over here on the right. Usually the difference is more than 15 millimeters of mercury in symptomatic patients with subclavian steal, and the normal side is the side with the higher blood pressure. The stenotic side is the side with the lower blood pressure. Make sure you understand this. They're going to ask you in board questions which side has the stenosis. Beyond the blood pressure discrepancy, another symptom that patients can develop is exercise-induced arm ischemia. They can get pain, fatigue, and numbness in the arm and the affected side. So you have relatively weak blood flow going over here to the left side because of this stenosis. And so the patient tries to use that arm and the muscles demand lots of blood flow. This arm is requiring blood backwards through the vertebral artery to supply oxygen, and that's often insufficient. So you get ischemia, pain, fatigue, numbness on the affected side with the stenosis. And then finally, rarely patients can get dizziness or syncope. Why does this happen? Well, if the pressure is low enough over here on this side, it'll draw so much blood away from the vertebrobasilar system that you basically get vertebrobasilar insufficiency. In other words, not enough blood flow to the brainstem like you should because of this subclavian steal physiology. And so in rare cases, patients can present with dizziness or fainting spells, all related to a subclavian stenosis, because that stenosis is causing reversal of flow in the vertebral artery and subclavian steal. And that concludes our module on vertebrobasilar stroke syndromes.